start the Q&A session early, solo. Anyone?
I noticed on the Hoover app, there was a message on there about needing to raise money for having the med students offsetting those costs to attend this conference. Has there been any thought given to having those of us that would be willing to come in to a conference a day early and have a golf fundraiser or something along those lines to help raise that money?
We're open to anything and everything, Kelly. It is one of those things that, everybody wants more med students here. Thing is, med students are poor. So when you talk about bringing a med student in, you're talking about travel, lodging, conference fees, et cetera, and it's expensive. So everything is on the table. I know Lynn Ann is in the room, and I know she heard your question. So I would just say that everything is on the table. And if anybody else has got any great ideas, we would love to hear them. But we do, as a goal, we want more med students here. I think we have a few, but the funds were very tight. As you all know, we try to run this conference at a break-even basis. We actually are in the black a little bit this year, which is good because, as you all probably have heard, come on up. We'll take you to the couch. You bringing mics? One mic.
One. Partially, one more.
Oh, Lynn Ann's got it.
You have a tab on.
Oh, I do. Duh. Okay.
Yes.
Well, what am I going to do with my hands?
Huh?
I had a conversation this morning with one of our good guy PBMs, and he said their company would send $500 a month to a foundation to support whatever the
Oh, wow.
organization. He said, we're not the only ones. And ultimately, our families underwrite this conference. So we've talked about doing that, but we set this up as a for-profit entity, so the federal government would have no leverage whatsoever. They could never jerk our tax-free status because we've said something that we weren't supposed to say.
And we occasionally do.
And we do. So, the concept of setting up a foundation is hot on our radar, I think, right now, because in all likelihood, this movement is going to attract the attention of people who are capable financially of endowing this, so it really is goes on in perpetuity. So, and it could serve that function too.
And we have run into, just to kind of close out Kelly's comments and thoughts on this subject, by being a for-profit entity, we certainly did that, to be, we wanted to be the pointiest stick around, right? And not have to worry about, the IRS not being happy with some of our comments. But kind of the unintended consequence of that is there are a lot of organizations that would be willing to support the efforts of the FMMA, but they have as a policy that they can only donate to tax-exempt entities. And so that's been kind of an unintended consequence.
Maybe for like a $5 million donation, we could let Edna join.
That sounds like a plan.
Okay. Well, tabled.
Thanks for having this conference. I have two questions. The first is when you start providing employee benefits, especially with zero copays, they become consumers. And when they can't just go wherever they want for free, then like you mentioned, Jay, they become a little unhappy. Any guidance on how to make all the employees feel good about saving the whole organization money?
Yeah, that's the dark side of financial incentives. In my career, it's been probably one of the things that just feels icky, and it's human nature. But you're absolutely right. Once you start providing something for free as an incentive, the brain takes that to an entitlement mentality where now if they can't go wherever they want to go and get it for free, they feel like they've taken advantage of somehow. And you're like, wait. The best antidote for that is education. It really is. This is not free. There's a reason why your employer is eliminating your out-of-pocket when you choose this, and here's what makes this facility special. If they choose Surgery Center of Oklahoma, we can talk all about price, quality, upfront bundled pricing, et cetera. And your hospital we would be more than willing to invite them to compete. And when we do that, sometimes the patient will get our little cash price agreement, that's what we call it. We'll get it thrown back in their face. We don't like that happens, but it does tend to reinforce the idea that you can't just go anywhere and get it for free, because not anywhere is willing to compete for your business and be reasonable.
Okay, thank you. The other one is, so as both a provider and a plan sponsor, I'm trying to learn both sides of the story, if you will. So as a provider, rarely does a PPO pay me any more than Medicare rates. So then as I go out and try to look at direct care pricing, and I'm told, oh, well, this saves you so much over the PPO, I'm left kind of wondering a little bit, and maybe over the PPO, but PPOs only pay me Medicare, so is direct care actually saving me over what Medicare would pay, for example? Reference-based pricing.
Yeah, I mean, most plan designs that are reference-based pricing, and we're talking about primary care that's not direct primary care, so not that model, but more fee-for-service primary care. The plans that we design actually try to put a little bit more meat on the bone for the primary care physicians, where we're paying a multiple above Medicare, 130, 140, 150% of Medicare, and we usually don't have any complaints or any friction from primary care when you pay them 130, because they're used. It's just like they're used to getting Medicare, or 98% of Medicare, or 103% of Medicare. So when you go out on a reference-based pricing design at 130, 140% of Medicare, primary care seems to be pretty happy. We rarely, if ever, do we get a balanced bill on primary care. It just doesn't happen. That's pretty much reserved for the upstream stuff. And that's not what's driving. That is not what's driving an employer's costs. Primary care is kind of a rounding error, but it's the referral stream that goes along with the primary care that's hurting people.
Hey, can you guys both speak to the biggest barriers of entry for Jay, for you for the TPA side, and Keith for you on the surgery center side for the kind of direct transparency model that this whole conference is about, and particularly if you could focus on the regulatory side and the financial side, and maybe the personnel operational side as well.
You want to go first? No, you go. Okay. On the benefit plan side, there are some things that you have to be very careful about as far as plan design and not violating any of the applicable laws. Nick Bonds from the FIA group was here yesterday, and he had a couple of slides, just nothing but alphabet soup, abbreviations for all these federal laws and everything. And I wish he had said this, but he didn't. And that is that pretty much every employer that a DPC or a facility works with, it doesn't matter if you're free market minded, alternative delivery, whatever, all that stuff does apply. And you've got to figure out how you innovate, make things smoother, more responsive to the buyer, et cetera, while also not being thrown in jail or getting the employer in trouble for a violation. So yeah, you've got to be careful, but it's doable. We're all doing it. Really, it's the classic, when you're talking about doing something that's alternative, there's the classic hurdles you've got to get over is usually the misaligned consultant that's in the shop. If they're a free market minded consultant, a health Rosetta consultant, that you don't have that issue. But for any of the other traditional consultants, it's a huge barrier. And in fact, it becomes antagonistic because a lot of times they're going to stick with the BUCA recommendations. and the employer has a relationship with this consultant. And so you're not, we talked about in our sales team, we have to make 2 sales. First off, we have to convince the employer why our method is a good deal. And then we also have to convince them why they shouldn't listen to their consultant, which sucks. That just sucks because so I have to make a sale and destroy a relationship that maybe has gone on for a long, long time. It's tough. And then the other is my comments. A lot of times, and I love my HR folks in the room, but a lot of times HR, if this is the first time they've heard it, they're resistant to it, just because it's different and it just sounds like a lot of work, and they're not sure about the benefit.
Yeah, I'd answer it 2 ways. For an existing facility, the obstacles and hurdles are mostly mythical. When I talk to another facility that is accepting insurance or Medicare payments, and we talk about doing this, they're real concerned about their running afoul of their contracts that they have with the carriers, and it's just simply not an issue as much as they think that it is. So there's that perceived hurdle that is not real. If you're talking about a hurdle or an obstacle for a facility to start doing this, the hurdles, the 2 rate limiting factors are the availability of surgical talent and preponderance of pissed off, non-naive buyers. So that's the magic soup. If you have motivated, angry, dedicated buyers and you have surgical talent, then those are the primary obstacles for, I think, the success of any kind of facility getting into this movement.
I wanted to share that there's a groundswell in another place. That's the employer space. So if you're not aware, there are employer coalitions on health in most every state. In Texas, there's one in Dallas and there's one in Houston. I'm Oklahoma, and the gentleman from Kansas, Arkansas, and I think he's got one other spot, has just joined the FMMA. So we've got an opportunity to kind of bring some voices together, and you may think that there's not an education going on. We're trying. We're trying from the employer side to bring as much information as possible to the decision-making process in the benefits space, because it is really complicated, it is really hard, and nobody actually trains people how to do this. Even if they did, it's changing so fast that you wouldn't be able to keep up with it. So we do want to hear from employers especially, but also the other partners in the industry. This is not something we do by ourselves. And this is kind of a Switzerland stance, but we're wrapping arms around and trying to bring everybody forward together. The strongest thing you can do is put your voices together.
How do we get those folks to this conference next year? Okay. Getting the buyer and the seller in the same room is incredibly powerful. And a lot of times you see physician conferences where they all sit and talk to each other, and then you see employer conferences where they all sit and talk to each other. If you get the middlemen out of the way and get the buyers and sellers talking directly to each other, that's when the magic happens. And then they'll bring the appropriate middle people to the table.
I have a question. You've spoken about the successes that you've had working with the employers, but how are you going about educating the employers and their HR staff that health insurance and a health offering is a value prop, an employee value prop, and changing this from a commodity and that it's a value prop to their company to offer this type of plan, and that when you're offering this type of plan, it's repeatable and sustainable?
Everything. A big key is right in front of you. It just sat down next to you. It's education. You have to have good people that are good educators. You have to have case studies. I start conversations with prospective employers that you need to forget about that you're buying insurance. You need to start thinking of yourself as a buyer of healthcare, and you suck at it, and you need help. And that's kind of that takes a mind shift. It really, really does. And I don't think a lot of employers think of it that way. I think they think I buy insurance, and then my insurance, they're going to handle, everything else. And so, that you're still a buyer. You're just basically ceding all of the decisions to somebody that's actually trying to profiteer on your ignorance. So yeah, there is no one silver bullet to it. It gets back to education, being able to get the employer to again see their role, see their employees' role, and those are both active roles. And some employers are ready for that, and some of them aren't. But they won't ever get ready for it unless they start hearing the conversation. They start hearing these things, and it takes time. We've come up with a lot of resources for our chapter leads, and I'm going to talk a little inside baseball here, but I won't name any names. But when we have our opening state chapter lead session on Wednesday of this conference, especially last year, I can remember being in that session where we had just rolled out a bunch of educational materials, talking points, et cetera, had them, professionally produced as a resource for our members. And I love you docs. I love you docs. But some of the DPCs were in the room, and they said, I just don't get it. I handed this stuff to the CEO, and they never called me back. I'm like, really? Really? So you mean one sheet of paper didn't completely unwind, a couple of generations of conventional wisdom? And so it takes a lot of time in the sales process, the sales cycle for this kind of a movement, unless the employer is red hot, unless they feel really burned and they are ready to take the red pill. Sometimes you'll run into them. But for the lion's share, they have just been brainwashed. They're like the frog, that won't jump out of the slowly heating water. They just will sit there and get cooked. And it takes time to get them to think differently.
Hello, Jay. Mark Horning here, to your right. There you go.
Gotcha. So thank you.
I wanted to compliment you first on your speech, the pragmatism of it, and your insight about the relationship between the CEO and the advisor. I've built a health media business over 19 years, and under the idea of information transparency, which is very parallel to the price transparency model that you do. The one tactical advice I would urge many to consider here is, if you can, get the CEO or the CFO in the room with the advisor when you make this pitch. It's a high-risk strategy because you will be thrown out more and never spoken to again, but you end up closing more deals, in my experience, when you tactically get them in the room at the same time and make your case. Because the case is pretty compelling that you're an advocate, we're all advocates, for getting employers to buy the best healthcare possible at the lowest price. Thank you.
Hi, I have a question for the both of you. Is there a question that you would like those of us in this room to be asking that we aren't? And if so, could you answer it?
Good question.
Now, if you had asked us that probably on the first day, I could probably come up with something, but I'm kind of cooked right now, so I can't think of anything. We've had great exchange, so how about that? This thing is, we've had a lot of great questions and lots of great comments. So if I think of one, I'll let you know.
I'll make it easy for you. I have the question. First of all, amazing conference. First time attending FMMA. Huge believer in the free market and healthcare. Jay, I was listening to your speech. Fantastic. One of the things I was thinking about during your speech was concept of care and driving the member to appropriate care. I think about the carrot and the stick model. It kind of exists, and also the relationship that an individual has with primary care. and the influence that primary care has over the member. And I'm curious, from both of y'all's perspectives, have you seen anything that works really well in allowing DPC to be this knowledge base and advocate for the member based on their health plan, their benefit design? Or are they kind of siloed away in a vacuum? What do you think works really well so that DPC is able to refer members to appropriate places?
That you hit on something there. It's not easy to find the best places. It's not easy to find the high value places. And one of the things that we tend to deal with, I got two answers to your question. One of the things that we work with our DPC partners on is a lot of times the DPCs will have a really great deal for labs or for imaging or whatever else. But of course they want to refer them, but then they also want the benefit plan to pay for them, which is what we want. But the deal that they have with the imaging center is only for cash or only for patient pay. And they won't file claims, or if they find out that a self-funded employer is the actual buyer, the deal's off. Or they won't provide the documentation for us to be able to adjudicate the claim and satisfy all the regulatory requirements. So that's a frustration for us, and it's a frustration for the DPC and the patient. We have a good database of high value medical providers, and the way that we kind of duct tape and baling wire that together is we work closely with our DPCs. We want them to, when they have an upstream need, for them to call and talk to one of our patient advocates. And our patient advocates then have access to all of that information. We want to get to a place soon where all of that information is also accessible to the DPCs. But that's an area of innovation right now, and there's technology out here in the hallway and others that are trying to link the TPA, the DPC, and the upstream providers together, and it's coming. It's just, I haven't seen anything that's perfect yet, though.
Yeah, and from Surgery Center of Oklahoma's, and we receive referrals from DPCs from all over the United States. One thing I think is astonishing, and Steve Lonte backed me up on this, is the extent to which local DPCs continue to refer away from high-value providers in the area. And it's a little bit of a head-scratcher, except, there are these relationships that many times even predate the decision of that physician to, embrace a DPC model. But we see that all the time. I would argue, as anesthesiologists, we know, which surgeons perhaps ought to be patronized more than others. We damn sure know who they shouldn't go see. But we still see some of that, and it ultimately works its way out when people find out. There's a lot of bad outcomes, but there's a lot of unnecessary referrals like that.
I would agree with that. I've actually had my own DPC want to know who's in network that they should send me to, and I'm like, ugh. So yeah, that is that. I think those old habits die hard.
But again, that's education. That's on us. We, maybe we should have a big open house and forum, and say, these are our go-to referral sources for surgery or specialty care. You ought to at least put them in your Rolodex if you're not calling them now. So really, it's kind of on us.
I think it's clear that the healthcare cartel is on a self-destructive mission. You can't go on this forever, just ripping off the public and increasing the cost, and at the same time decreasing the quality. We now have a new administration. Now, some of this is by law under Obamacare, and so there's certain things they can change and certain things they cannot change. But is there any feeling by the people who are insiders that these new appointees of Trump can change the trajectory of the healthcare system and make it better? I think, to me, it looks like they're almost deep-seated, worse than the deep state in the politics part of it. The medical care, and it seems to transition from one, and the medical care problems seem to transition from one administration to another. It's like they're almost powerless to do anything about it. So hopefully these new people will be able to change something, but I'd like your opinion on that.
Yeah, I'm cautiously optimistic. However, everything the state touches turns to trash, regardless of their intentions. When the first executive order for price transparency was signed, Jay predicted one bad outcome, and I predicted the other, and they both came true. You don't mandate price transparency. I mean, things that ought to happen that are great ideas happen not at the end of a bayonet. But Jay's prediction was that they would redefine price transparency. And that's what they did. It wasn't 2 or 3 weeks when somebody, after that was signed, somebody told us the new definition of price transparency after the executive order is what is the patient's out of pocket. And, the insurance company, carriers got in there and got busy. My prediction was that Congress would sell indulgences. They would basically sell exceptions. And that's what they did. And that's the fine structure was basically created so that the big players could just violate it and they would just sell exemptions. And so it became just a moneymaker for the auction house, the first executive order. I don't know what this second executive order does. The only really good thing I'm seeing, there are two good things, possibility. One, the narrative has changed. And I think the narrative has changed because price transparency that's a phrase. I mean, that people know that phrase all over the United States. The other thing I'm optimistic about, and I don't know if it's wishful thinking or not, but site neutrality, payment to independent facilities that matches this payment for the same service to hospital-owned, non-independent facility being equal changes everything.
Amen.
And site neutrality is gaining momentum. So right now, hospitals own an ASC, they get paid 2 to 5x what an independent surgery center would get paid for the same service. And then the hospitals use that money to do all the things they do, the most damaging of which is to hire physicians and make physicians employees. And then when they do that, quality goes in the toilet because the primary care doc is not independent anymore. They have to refer to the butcher at the end of the hall, who they know is horrible, and they can't refer to the best surgeon across town. So site neutrality is the thing, that's a game changer if that happens. And that's kind of what I have my eye on more than anything.
Yeah, the best kind of price transparency is the kind that, for the employers in the room, that you just refuse to do business with a medical provider that does not offer upfront bundled cash pricing. That's the best kind of transparency, where it is to their detriment that they're not transparent, and not some federally mandated number of fields that they need to have in a database, but something that every man, woman, and child can readily understand at the point of service. That's, in other words, price transparency as defined by the buyer. That's what needs to happen. I think we're out of time.
We're out of time.
Thank y'all.